Hello, my name is Ravi Vij. I'm from My Cancer Haven. And today I have with me Dr. Gurbakhash Kaur, who is assistant professor at UT Southwestern Medical Center in Dallas, Texas. And we're going to talk about a novel therapy that is likely to be approved in the not too distant future here in 2023 in the United States called Talquetamab. So welcome, Gurbakhash.
Thank you, Dr. Vish, for having me.
It's a pleasure to have you here. So for our audience, first of all, I think a lot of them have probably had daratumumab. Some of them may have had isatuximab and implicity. These are monoclonal antibodies. But bispecifics obviously are a new development. We just had the first one, Talquetamab, approved. But what are bispecific antibodies? How do they differ from monoclonal antibodies?
So a monoclonal antibody like Dara or isatuximab or implicity, they have the ability to only bind to one antigen. So in this case, in the case of daratumumab and isatuximab, they bind to CD38. So only one binding possibility. Whereas a bispecific, what it does is it has the ability to bind to two things. So it can bind to something that's expressed on the myeloma cell, so a tumor antigen. In the case of Talquetamab, that's BCMA. In the case of Talquetamab, it's GPRC5D, and also at the same time can bind to CD3, which is expressed on the T cells. And by binding to both of these things at the same time, it's able to bring the immune system close to the myeloma cell and actually stimulate an immune reaction against the cancer cells.
So that's amazing. Obviously, these are things that we weren't able to do just a few years ago. And as we'll discuss, it seems like these are very promising.
Yes, very much indeed. We're very fortunate in the myeloma world because we have had, several drugs approved in the last decade or so. And every time it's progress. We went from monoclonal antibodies to CAR T cell therapy, which is also utilizing the strength of our immune system, and now to bispecifics, which, they sort of have a similar effect as CAR T, but they're dosed on a weekly or every other week basis, and just it works in slightly different way than a CAR T cell therapy. So as you can see over here, we have SLAM-F7, which is we have a drug against that. That's elotuzumab or implicity. You have CD38, which is a target in myeloma, and we have daratumumab and isatuximab that's been developed, and obviously BCMA, in which we have belantamab mafodotin, which was an antibody drug conjugate, and then CAR T cell therapy such as ide-cel and Carvykti, which have already been approved, and then obviously now the bispecifics such as Talquetamab, and there's others in that class such as belantamab and several other companies that are working on it. And now we have, against the GPRC5D, we have a bispecific antibody such as Talquetamab. There's also a CAR T that's in development that targets this antigen as well. And then another antibody that's a bispecific that's in production or in research is the FCRH5.
So we obviously have a lot of candidates to a variety of these. Our discussion is going to a little bit home into the GPRC5D target, and that is where Talquetamab comes in. So GPRC5D, it's a surface molecule. Is much known about this? What does it do? Is it something that we've known about for a long time?
I think so. GPRC5D is highly expressed on myeloma cells. It's called G protein coupled receptor family C group 5. That's the official name of it. Only in the recent years have we started working on as a therapeutic option in myeloma. And it's mostly expressed on plasma cells. It can be expressed on some hard keratinized tissues, and otherwise it has a low expression in normal human tissue.
So when you say keratinized tissue, I guess you're meaning skin and nails.
Yes.
And then I understand, we'll talk about it, it also has some expression on the back of the tongue, perhaps.
It can, but I think yes, because that can also lead to some side effects when, we can talk about that when we get into that phase.
Sure. So this drug is now before the FDA for what we call accelerated approval, which means that the drug is promising enough that the company feels that the FDA should approve it based on a trial they've done. They haven't yet compared it to anything, but it seems to work when literally everything else has failed. Is that not for everybody, but for a substantial majority? Is that the reason why people are excited about this?
Yes, I mean, I think there's lots of reasons to be excited about Talquetamab based on the phase 1 trial called Monumental 1. This trial was done in a population that was heavily pretreated. Essentially 70, the trial was done, it had several cohorts. One was the drug was given in a subcutaneous fashion in a weekly dosing, which is the 0.04 milligram per kg. And then the other cohort was 0.08 milligram per kg, which is dosed every 2 weeks. There was also another cohort where it was given intravenously. Well, I'll mostly focus on the subcutaneous aspect of it. And in this trial, 100% of the patients were triple class exposed, but I think close to 77% of the patients in the weekly cohort were triple class refractory. So which means refractory to an IMiD, a proteasome inhibitor, as well as daratumumab. And this number was sort of universal. It was in the 70 to 80 range in all the different cohorts that were there. And essentially, and a small proportion of it was also penta-refractory. So, we're excited about this drug because once we've sort of progressed on the most commonly approved regimens or treatment drugs such as daratumumab, isatuximab, Kyprolis, Velcade, pomalidomide, and Revlimid. These are the drugs that a patient sort of sees over their lifetime. What options do we have thereafter? So this drug is showing very, very high rates of overall response rates ranging in the 74, 73% range, and then very good partial remissions as well, close to 50 to 60%. So that is definitely a reason to be excited because this is not the usual response rates if patients were not to get anything experimental like this, just in standard of care that they get, which is usually recycling some of the drugs that they may have gotten before at this point,
Yeah, so you mentioned about penta-refractory, which means refractory to the 5 major drugs that we have, and this is subcutaneous given under the skin, so it's a convenient mode of administration. And to put it in historical perspective, I guess in this drug produces responses, as you said, in 3/4 of patients. Earlier, we used to get drugs approved that just worked in 1 out of 4 patients, or only 20% of patients in a similar state of their cancer journey. So this is a quantum improvement, correct?
Yes, this is a major improvement. Just a few years ago when we had the first BCMA targeted agent approved based on the DREAM2 study, that overall it was 30% sort of what we were usually seeing. So this is a huge this is quite amazing, the response rates we're getting. And also, it's not just about the response rates, it's how deep the responses are as well. And that's key. Over here, you can just see, the stringent CR rates of 20% and the very good partial remission rates almost of 50 to 60%, which I think, is wonderful.
Yeah, so by VGPR, you mean a 90% decline in disease burden, and a stringent CR, meaning that with the bone marrow and blood tests that we do routinely, we can't find any trace of the cancer. So that's really, and this seems to work even when the new classes of drugs that we're so excited about, BCMA-directed therapies, CAR T cells, and bispecifics also are no longer working. So this gives an opportunity even beyond that.
Exactly.
And so
this is very exciting.
So obviously, you produce great responses, you produce deep responses, but another thing that I guess is exciting is how long these responses are lasting.
Yeah, I think in all this is amazing. in those, you can just say per the graphs over here, the duration of response is durable. So it's not just like it's a month or two, it's very long. So I'm very pleased with that as well.
So again, to put in perspective, some of the drugs that we used to get through the FDA a few years ago, the PFS, which is progression-free survival, or the time it takes before you break through the drug on an average for the population, used to be 3 to 4 months. And now we're seeing figures of close to a year.
Yeah, exactly.
And when these move into, as all cancer drugs do, they start their journey when other options are thinned down, but then advance through to earlier lines of treatment, they're likely to produce even greater benefit, because that is always the case. That whatever works in later stages, when cells have acquired a lot of resistance, they kind of are likely to be less resistant in earlier lines of therapy.
Yes, that's exactly right. And that's how drugs, daratumumab was used, for example, or even ISA not yet, but mostly daratumumab we have experienced, was approved in the later lines, and over time it's now sort of moved into the upfront setting. And I sort of see the future of Talquetamab going like that. I think there's already probably trials that are being planned, where the bispecifics are being tested, in earlier relapses, to see how well they do in that space.
So obviously, any drug is going to have some side effects, and we know that CAR-Ts and bispecifics do have this side effect of CRS and neurological toxicity. Can you expand a little bit on what CRS is, what the neurological toxicity is?
So CRS it's called cytokine release syndrome, and it's usually seen in patients who are getting immunotherapy, particularly chimeric antigen receptor cell therapy, which is called CAR T cell therapy, or they're getting the bispecific therapy such as Talquetamab or Talquetamab, and it's usually activation of the immune response. And while we want that, because the mechanism by which the tumor cells are being killed is by an immune-mediated response, sometimes the response can go a little, can be a little too much for the body to handle. And there's a whole grading mechanism of how the doctors and your team assesses of how aggressive the CRS can be. It can be graded grade 1, 2, 3, and 4. And usually, in CAR T cell therapy, we see the higher grades of CRS in comparison to what we're seeing with bispecific therapy. And usually the treatment is early recognition, close monitoring. So symptoms can be as mild as just a temperature or recurrent fevers, and which can be managed with Tylenol, or if it's and it could progress to the point where patients can have low blood pressure or have a little bit of oxygen requirement, to the point that the blood pressure cannot be maintained by itself, and the patient needs IV fluid support as well as pressor support and needing an ICU. So it's a whole spectrum of what we see in the clinical practice, and our goal is to recognize it early and intervene early, and that's what we do. Neurologic toxicities, it's what's called ICANS, and it can be as very mild as having headaches, or just a speaking difficulty or word finding difficulty, to point that some people get really altered and require close monitoring in the ICU for that. And that also, the cornerstone of management of neurologic toxicity is also early recognition. And when patients are getting these therapies, they're being closely monitored by the nurses and the staff on the floor, and the treatment is usually dexamethasone. So I think these are the two major side effects that we worry whenever we do CAR T cell therapy or bispecific therapy, and we keep a close eye on patients. And what we've seen in the Monumental study was that majority of the CRS that was experienced was grade 1 or 2. It was only in the weekly dosing where I think there was 1 grade 3 CRS, which is pretty good. So we're lacking the side effects profile over here in terms of being able to manage this. And while right now we're having the clinical practice of doing Talquetamab in a commercial manner, we're having patients coming and being admitted to the hospital. I think the future of this is that as we can control and manage CRS better, this can these therapies can eventually move to the outpatient side as well. And similarly with neurologic toxicity.
So the thing
I hope
is,
I answered the question.
oh yeah. So the thing is that I guess you mentioned the patients are in the hospital, and you mentioned the CRS and neurological toxicity. So in most of these bispecifics, we start at a low dose and we go to an intermediate 1 or 2 doses before we get the full first dose. I understand that once you've been through this to the first full dose and you start then giving the second full dose and beyond, the chances of these neurological effects and CRS are way down, or literally they go away. Not totally go away, but it's like very little.
Yes, you're very much right. So there's the step-up dosing that happens, and that's essentially to sort of to prime the system a little bit, one step at a time. And usually, if you get to the main dose, these side effects are not seen.
And then obviously, one of the things that we get worried about with our treatments is effects on blood counts. So is this one that is very likely to suppress your blood counts to very low levels? Because that's obviously what patients get worried about with infections and bleeding and need for transfusions.
Yeah, I mean, I think when you're dealing with infections and low blood counts, you're sort of in a rock and a hard place, because if the myeloma is untreated and takes over your bone marrow, patients become what we call cytopenic. They have low blood counts to begin with, and myeloma itself is sort of a dysfunctional immune system. So myeloma patients in general are prone to getting infections, right? I mean, if I look at the data that was published on Monumental 1, I think if you look at anemia, neutropenia, lymphopenia, and you look at sort of all grades between the different dosing cohorts that was done, cytopenia is where I'm just sort of giving a summary, was sort of seen in the mostly 30 to, in the 30% range. This is sort of just an estimate of what I've noted as well. So it's there, but it's also there, especially given how far patients are away from their diagnosis and how refractory the disease is. You sort of pick and choose and weigh the risks and benefits of this therapy, right?
Still much better than what we have faced with some of the other options that we have in the past had to limit ourselves to, like very intensive chemotherapy where the blood counts go very low and transfusion needs rise. So I guess that's good. Now, the other thing I guess there's a more recognition about with bispecific is risk for infections, and that is something that it seems like this may be a little gentler on the infection front. So what are the kind of infections that we have to look out for, and what do you have to do to minimize the risk for infections?
So you're right that in this trial, the infection risk wasn't as high as what we were seeing with Talquetamab, and that may be because of the target that they have, right? PCMA versus GPRC5D. So the target obviously has an implication on that. I think we're very proactive at our center in preventing infection. So most of our patients at this point are hypogammaglobulinemic, which means they have low IgG. So we tend to put them on prophylactic IVIG, and our threshold is less than 400. That's when we start. And we, patients are seen periodically and very closely in our offices. So there's early recognition of infection. That's sort of what we do. Many of our bispecific patients, we have them on PCP prophylaxis as well. And I tend not to do, you can do oral antibiotics in terms of Bactrim as well. But because Bactrim is harsher on the bone marrow and also can cause you to have low counts, we tend to do pentamidine at our center, and that's sort of very provider specific as to what they like and what they don't like. So those are some of the measures that we take.
So PCP obviously is a bad kind of a pneumonia, and the immunoglobulins obviously help fight infection. And then do you, at our place, we also try to prevent herpetic infections and shingles with the use of acyclovir. Is that something you do as well?
Yes. Sorry, I sort of just take that for granted, because the moment a myeloma patient gets diagnosis, the one drug that we usually never take away unless they go on to maintenance is acyclovir. So I tell my patients, I said, this is a multiple myeloma vitamin, acyclovir or Valtrex. Yeah, so that goes without saying. Of course, patients are on acyclovir or Valtrex, depending on their preference during this time as well.
So some of the unique toxicities that we hinted upon earlier in our discussion just merit a little more discussion, I guess, at this stage as well. First, the skin and the nail toxicity. So what is it that this drug does to the skin and the nails?
I think this has to do with the fact that maybe not maybe, but GPRC5D is expressed on the keratinized tissue, like I said, at low levels. So it may be an on-target effect. So patients are getting, grade 1 to 2 rashes. That's what mostly was seen in this trial. And they resolve if you hold the drug and you decrease exposure. They have mostly resolved. So that's what was seen. And the dyschezia was also seen, but that was managed pretty much with supportive care during the trial.
So the nail toxicity, I've seen some patients unfortunately lose their nails, but you said the skin toxicity is obviously usually mild, and usually an emollient or a cream or sometimes a steroid cream is all that is needed. Then the dysesthesia. So I know that this is something that is somewhat unique to this drug. We know that this GPRC5D receptor is present, I'm told, not on the taste buds, but on the back of the tongue, which helps in the mechanical act of swallowing the food once it's been minced. My patients have said, their taste is altered, but it's more like they're chewing on cardboard. And unfortunately, solids may sometimes lead to inability to swallow, and they're often for a period of time on a liquid diet, and they unfortunately can lose weight. So is that something that you've also heard and encountered?
I mean, I think when myeloma, I very much agree. I think the management for dysgeusia is essentially supportive care and trying to help them get through this phase where, and I sort of give my patients a liberation. I'm like, eat what can go down and what tastes good to you, right? This is not the time that you want to be picky, and you want to just maintain their weight and get them through it. Because oftentimes at this time, the disease burden is ongoing, and that also is sort of affecting the patient's appetite and overall ability to gain weight. So I think there's multiple things going on, but I agree with you in terms of managing it with supportive care, and that's how they sort of managed it in the trial as well.
So the thing is, the good thing is that I've had patients that had this, but a few weeks or months in, it started being something that they adapted to. I must admit that some of my patients did lose a significant amount of weight, but the other good thing I think about this drug is if it works pretty fast. And once you have the disease under control, you can even reduce the dose and give some treatment breaks if it's getting too extreme,
Yeah, I honestly think that's going to be the future of myeloma therapies. I think up until this point, we focus on getting effective therapies, and we've been not, the myeloma community, scientific and, and clinical, have been very good in getting to that point. But we're becoming more patient-centric and realizing that quality of life matters, and treatment breaks, and especially if they achieve good responses, like you said, that's the time to do it. So I think more future trials in myeloma that are going to study this are also going to have sort of limited duration therapy. And clinicians do this, off label all the time. We listen to the patient, and depending on their symptoms and response, we make along with the patient, make a decision to give them a break.
Yeah, I think that's very true that, in the past 20 years ago, when we treated myeloma, we used to give treatment for a fixed period of time and give them a treatment break and reintroduce treatment when things started getting worse again. And that was partly because the drugs were so toxic that you couldn't continue them for long periods of time. And then we entered an era where the drugs were more user-friendly. They didn't have as good a response as this. So you often didn't want to stop it because you feared that the disease was not totally gone. But now these drugs at least bring the disease down so fast that we're re-exploring the idea of maybe engendering the paradigm of treatment breaks again. That's exciting. Now,
Yeah.
this drug obviously is available on clinical trials, and there's even an expanded access program that for patients who may not qualify for trials that the company has, that the institution would need to obviously have open at their center for them to avail of the drug. The good thing is, hopefully later in 2023, this drug will be available for our patients.
Yes, I can't wait to get to that point, to be honest.
Well, I really thank you very much for walking us through this exciting drug that I think patients should be starting to know about, because it's coming to a pharmacy near them very soon, I guess. So
Yeah.
again, thank you very much for joining us. And I hope I can count on you to return and educate the patients about another topic in the future.
Well, thank you for having me. It's been a pleasure to talk to you.
Thank you.